Hello, friends. Yesterday we saw the different articles that said OADs as well as insulin can be used with equal ease, and either of them can be first-line treatment in the glycemic control during pregnancy. So today I will talk about the OADs, that is oral anti-diabetic agents. That's the new name of it. Earlier we used to call oral hypoglycemic agents. They are now anti-diabetic agents. What are the classification of OADs? Those that enhance insulin secretion, that means they are insulinogogues. We have sulfonylureas, then meglitinide analogs, and dipeptidyl peptidase 4. In that, only sulfonylureas are highly studied and used. The next category is those that overcome insulin resistance. Probably this is most suitable for pregnancy, as I told yesterday, because GDM is mainly due to insulin resistance during pregnancy. So those that can overcome insulin resistance are logically the best OADs. We have biguanides and thiazolidine group of drugs. Then there are others like alpha glucoside inhibitors, amylin analogs, dopamine D2 receptor agonist, but these are not at all used in pregnancy. So we are left with only two groups, those that enhance insulin secretion and those that overcome insulin resistance. In that, I said sulfonylureas are the commonest ones that are used. Let's look at that. Again, there are two generations of sulfonylureas. First generation, acetohexamides, tolazamides, and tolbutamides. They create a lot of neonatal hypoglycemia and threefold increase in anomalies. That's why probably, as I told you yesterday during my undergraduate days, we used to say they can cause teratogenicity. That's why all OADs were banned. Probably this group was the one which was giving rise to anomalies, and that's why people were scared to use OADs. So that is out, not recommended anymore. Whereas the second generation consists of gliburides, glibenclamides, glipizide, and glimepirides. These do not cross the placenta and there are no fetal adverse effects. That's why probably they are used. The last one is secreted in milk, so avoid in lactating mothers. Now let us look at the mechanism of action of sulfonylureas. We already said that they are insulinogogues. So what they do is they stimulate secretion of insulin from functional cell mass of pancreas. So in other words, when you give these drugs, actually indirectly you are stimulating or you are giving insulins because they stimulate the production of insulin. That's how they act. At least 30% of functional beta cells are required for sulfonylureas to act. If the pancreas is totally damaged, then this drug is of no use. This is another reason why these drugs will immediately bring down the glucose levels, because they indirectly help the secretion of the insulin, and insulin is the one which is released when you take these tablets. That's why the glucose levels come down drastically, which does not happen with metformin. That's the advantage we saw in most of the studies yesterday. They enhance the insulin sensitivity also a little bit in peripheral tissues, but not to the extent of metformin. They increase in number of insulin receptors in the cells. There are adverse effects of sulfonylureas, however. They can cause hypoglycemia, which I told you, that is the danger. And insulin is released even at low glucose concentrations. They can also induce weight gain because they secrete insulin. Insulin is a growth hormone. Yesterday I was telling you that insulin, when you give insulin, there will be increase in the weight, though it controls the sugar. Nausea, vomiting, of course, this is the typical undergraduate answer. When you don't know what to write about the side effects, you say nausea, vomiting, and to your shock and surprise, you will be correct. Constipation, headache, and paresthesia. So these are also some of the adverse effects. What is the dose of sulfonylureas? Always you start with very low dose, 2.5 milligrams in the morning. If the target is not reached, add another 2.5 milligrams in the morning dose itself. So totally 5 milligrams in the morning. After 3 to 7 days, add 5 milligrams in the evening if needed. So you start with 2.5, add 2.5 in the morning. If it is not controlled, then 5 in the morning, 5 in the evening. Increments by 5 milligrams thereafter, but a maximum dose of 20 milligrams per day. To tell you the truth, we do not use it in Manipal, and I have no experience of using this during pregnancy. Metformin. Advantages: pre-pregnancy control of sugars. This is the one which is very, very commonly used nowadays, be it just diabetes before pregnancies, type 2 diabetes, or if the patient was having PCOS and insulin resistance, or some people have the habit of just adding metformin to the ovulation inducing agents. Whatever it is, they are used pre-pregnancy, and they can be continued in the first trimester, as I told you yesterday, especially if it was used in infertility patients with PCOS, because the earlier papers said that it can prevent abortion, but the recent articles say it really does not decrease the incidence of abortion. So there is no point in actually continuing up to first trimester. That was the prescription in the few years ago. It prevents abortion, that's what I said, but it definitely does not prevent GDM in PCOS patients. So what I said yesterday, I will repeat. It does not prevent abortion as well as it does not prevent GDM. However, if the lady develops GDM during pregnancy, then you can restart metformin, which was stopped after she conceived. No severe hypoglycemia with this. That's the single best advantage of metformin. Minimal placental crossing compared to other OADs. It does not stimulate fetal pancreas. This is very important. That's exactly why there won't be macrosomia in the baby. There is lesser incidence of macrosomia. That's what I just said. And minimal secretion in the breast milk compared to the sulfonylureas and other types of drugs. Adverse effects I put as a big one. No serious adverse effects, but other things can be there. Like I told you, mainly GI symptoms: anorexia, bloating, nausea, metallic taste, diarrhea, and vitamin B12 deficiency. That's exactly why initially when the patients are on metformin, they do not eat much and they tend to lose weight and they think that it is a weight-losing tablet. What is the dose of metformin? The starting dose is 500 milligrams in the morning. In medicine textbooks, you may see that it has 835 and all that, but most of the formulations that we get are 500 milligrams. So we can start with 500 milligrams in the morning. After 3 to 7 days, you may add another 500 milligrams in the evening. Morning dose is fine because it's a long-acting one. You need not increase in the morning. You can add in the evening if needed. Then onwards, the increments by 500. It was 5 milligrams in sulfonylureas, whereas it is 500 milligrams increment. Maximum dose, there we said 20 milligrams. Here we are saying 2000 milligrams. Very easy to remember. But this is the one which we always use. What are the contraindications? Are there any contraindications for metformin? Yes, hypotensive states, alcoholism, it can cause disulfiram type of reaction, and severe respiratory and hepatic and renal disease also it is contraindicated. What are the concerns of OADs in general? Transplacental passage, but it is minimal with the metformin especially. Fetal teratogenicity, almost none, because we have now avoiding the first group of sulfonylureas. Hyperglycemia, it's mainly with glyburate, not so much with metformin again. Hyperbilirubinemia, not severe. Polycythemia, it is very rare. So hardly there is any concern with the OADs, so you can use it now. What is our experience at Manipal? We don't want to just talk without using these drugs. This was the paper presented by Dr. Nazia along with me, and maternal and neonatal the outcomes were comparable, whether the patients are treated with diet alone, metformin or insulin. The most important thing is control of sugars, then the way it is controlled. And metformin being oral, cheaper and convenient, it may be used in cases where diet alone is not enough and sugars are not very high. Once the sugars are not controlled, I told you yesterday also, 30% of the patients on metformin may require additional insulin, especially if they were the cases of OAD. Yes, so far it is or it was outpatient treatment, and you would ask the patients to have the sugars done maybe once in a week. That's enough because the sugars were not very bad. She was being able to take it orally. But now when the sugars lose the control, to start insulin therapy, you need to hospitalize the patients because nobody knows the exact dose of insulin. It's always with trial and error method. You start with some dosage and then you stabilize the dosage, only then you can send the patients. So when you're trying to stabilize the dose, it is better they are hospitalized because you need to do the insulin levels very often, and you may have to keep on changing the insulin levels also often. So if they are outpatient, it is very difficult to do that. To manage ketoacidosis, suppose the patient goes into ketoacidosis, there's no way you can manage them on outpatient basis. Hypoglycemic coma, sometimes it can happen. Patients are very scared and they eat very, very less and they go into hypoglycemia and ketoacidosis because of hypoglycemia rather than hyperglycemia. Severe polyhydramnios. This is one of the complications of uncontrolled diabetes. In fact, in the exam, when they ask you without doing sugars, can you say that the diabetes is uncontrolled? Yes, the answer is here. If the lady develops polyhydramnios or macrosomia, it obviously means these are the clinical indicators that the sugars are not under control. You don't even have to do blood sugars. Development of preeclampsia. Now there's a double whammy. Patient requires admission not only for management of diabetes, also for the management and monitoring of preeclampsia. After all, they are cousins. I told you yesterday the two important and closely related diseases are hypertension and diabetes. It's the same thing in pregnancy as well. And of course, when she has completed 37 weeks, it's time to deliver. We better have her in the hospital so that you can closely monitor the fetus, because most of the diabetic patients, the sudden intrauterine death occurs after 37 completed weeks. So you have to be very, very careful after 37 completed weeks. Many a times, earlier we used to say achieving 37 completed weeks is good enough, you deliver them. But lots of studies, lots of people, they say that you can take them up to 39 completed weeks, especially if the sugars are under control, because now this 39 weeks is considered very safe. The incidence of RDS is almost zero. That's why, that 37 completed weeks onwards, it is divided further into 3 levels. Number 1 is early term, full term, and late term. Earlier, everything was considered as term. So early term, the incidence of RDS is almost same as late preterm. That is between 37, 0/7 to around 38 by 6/7. This is the style of telling. These 2 weeks, there are still chances of RDS. That's exactly why 39 0/7 and 46/7. These 2 weeks are the best weeks to deliver, and especially these are the patients with medical disorders. They should not cross EDD. So I wouldn't even say that 30 or 40 plus weeks. It is only 39 0/7 to maybe 39 6/7. They should be delivered. No question of taking them beyond term. Antenatal insulin therapy is a very important question. It can itself come as a short note or a full question for the postgraduates as well as undergraduates. Insulin therapy, as I said, nobody knows what is the starting dose, where to start, how much to start with, and how to continue this. 30% of women on metformin require insulin. This is the 30th time I'm telling you this. Regimen should be adapted to an individual's treatment goals, lifestyle and diet habits, age and general health, motivation to take injections, and capacity for self-management. Sometimes they may themselves have to give the injections. Others may be scared to do that. Social and financial circumstances. I told you insulin will cost a lot. but that also is a factor to be considered. What's the dose? It's called Yaksha Prashni. That means nobody knows where is the dose. Long ago, one of the professors in Manipal, when I was PG, she taught this, and we have been following this last mostly 35 to 40 years now, that we may follow this, but there is an easier method I'm going to teach in the next slide. This is textbookish dosage, that is first trimester 0.7 units per kg per day. But I think this is too much. Suppose an average woman weighing, let's say 70 kg, are you going to give so much, almost like 40, 50 units? Second trimester 0.8, third trimester 0.9, easy to remember those 0.7, 8, 9. And then at term around 1 unit per kg, that means around 70 units per day. It's too much. Usually, what happens is 20 to 32 weeks, the insulin requirement physiologically increases up to by around 50% of the initial dosage. So now I'm telling you what that professor told us and what we have been following in Manipal. We start with Actrapid, that is, fast acting or short acting. We have to start somewhere. We start with 4 units. That is pre-breakfast, pre-lunch, and pre-dinner. You must be very curious why this person is not telling the name of the professor who taught this. Of course, it was Dr. Kuntal Rao, who was our professor and HOD. She came from PGI Chandigarh, and she brought this sort of regime to Manipal, and it has stuck with us. So we have to titrate as per sugar profile twice a week. We do sugar profile twice a week. There is a lot of controversy about this. People say it's too much to do sugar profile. What is sugar profile? Sugar profile is fasting blood sugar, post-breakfast, post-lunch, and post-dinner. 4 values. Usually they say patients will run away from the hospital, but we have to convince the patient that's very important. In medicine, they do pre-lunch, pre-dinner, and pre-meal. But it is always better to do post during pregnancy, because the insulin secretion usually happens after the food, and the food is absorbed very slowly in the pregnant ladies. So because maybe of the due to progesteronic effect of the bowel, slow bowel movement or whatever it is. So there is no point in doing pre-meal. It is better to do post-meal. And in that, there is no point in doing 1 hour. It is better to do 2 hours for the same reasons what I told you, that the absorption is delayed during pregnancy. So we do postprandial 2-hour value. And as I told you yesterday, it's very easy to remember 2-hour value. 2 hours have 120 minutes and the value should be 120. So 4 times a day, twice a week, we have to do in the probably initial days when we are trying to titrate the insulin. Once the target sugars are achieved, then we switch over to Mixtard, 30-70 and twice a day regime. Now, Actrapid, you have to give 3 times a day, and it is very short acting, as you know, but most of the physicians are comfortable giving Mixtard. And Mixtard consists of 30 short acting, 70 isofen long, intermediate to long acting. And the advantage of this is that you can give it twice a day regime. Now, what is the logic behind giving twice a day regime? In medicine, first I will tell you, and that we extrapolated to pregnancy. And that is being followed by most of the people, and most of the textbooks also give that. But I'm going to tell you, there is a slight change in the recent past. I will tell you that as well. But let's first understand this simple logic. The simple logic is that you give 2/3 of the total dose in the morning and 1/3 of the total dose in the evening. Let me say, give an example to you. We kept on, let's say, increasing the insulin. Morning, it was 4-4-4 we started, and when we reach 12-12-12, let's say, that day the sugar levels are stabilized. So that day, how much we have given totally? 36 units, isn't it? What you do from next day, you use Mixtard, 2/3 in the morning, that is 24 units in the morning, and 1:30 in the evening, that is 12 in the evening. Now, how does it help us? It is almost physiological insulin output. That is 2 peaks and 2 plateaus. What do you mean by 2 peaks and 2 plateaus? This is what is called genetic memory. Our ancestors had a very good meal in the morning. So whenever you have food, insulin is secreted, that is known. And when the food was taken in the morning, there was a big peak of insulin in the morning. And thereafter, there was a plateau. So first peak and first plateau. And after working whole day, the peasants, probably our ancestors, they came home and they had another meal in the evening. So again, there was one more peak of insulin, and throughout the night, there was a plateau. So this is the 2 peak, 2 plateau theory. So when you give morning 2/3 of Mixtard, Mixtard has got 30% of short acting, which will immediately act, and that will help us creating that peak, morning peak. And the 70, which is intermediate to long acting, will give that plateau of the morning. So this 30 is giving the peak in the morning, and 70 is giving the plateau in the morning. Morning, we have heavy breakfast or heavy things to eat. That's why we give 2/3 in the morning, and later in the day also we may be eating. Whereas in the evening, we are supposed to eat little lighter. That's why you give 1/3 of the insulin, and that 30 will create a peak, 70 will create a plateau. Now, this looks perfect on the paper. It looks perfect in the book. It looks perfect when I'm teaching you. But the food habit of people have changed so much. Nowadays, many youngsters, they don't even eat in the morning. They don't have breakfast. And same thing, they continue when they become pregnant as well. So I was talking to our endocrinologist in Manipal, Dr. Shetty, Sahana Shetty, and I spent one whole hour with her. She taught me very nicely how it has to be slightly different with the modern culture. So what she said is that you can start with the same 4-4-4, it's all right. But you have to add one post-dinner isophane of 4 units as well. I asked her, why is this? I thought in the whole night we don't eat anything. So if you give in the night, then you will have very severe hypoglycemia in the morning and all that. But if you remember, during pregnancy, there is exaggerated fasting hyperglycemia, rather hypoglycemia. So, but if there is hyperglycemia, that suggests that there is GDM. That's exactly why the fasting has been brought down to 92 because of the exaggerated hypoglycemia. Whereas in medicine, non-pregnant ladies, they have still kept it at 125. So what is the cause of this fasting hyperglycemia? So fasting hyperglycemia is not because of the food that you eat. It is because of the neoglucogenesis that happens in the liver. To take care of that, you have to give post-dinner isophane 4 units. So 3 peaks in Indian food habit. We eat in the morning, we eat in the afternoon, we eat in the night again. So it can be managed by Actrapid. And fasting blood sugar is not due to food. That's what I just now told you. That can be managed by post-dinner isophane, that is long-acting, intermediate-acting 4. So this is actually leading to 4 injections, but according to her, this is the best way to manage. She has done a study in Vellore, and she came from Vellore, and she explained this to me very nicely. So as per that, food habits, 3 peaks, not 2 peaks, and fasting blood sugar is not due to food intake. So that will be managed by this. So here it is, morning, you are giving Actrapid. So that is causing a peak. Afternoon, you are giving an Actrapid, that is causing second peak. Sorry, these are interchanged here. And pre-lunch you are giving. I'm starting with dinner because I can show the action of that isophane, what you give after dinner, and it is coming down there. So it is 3 peaks and 1 plateau. not 3 peaks and 3 plateau. I hope I didn't confuse you. It is very, very clear and interesting. Insulin analogs. Now, the physicians make fun of obstetricians always because they think that we always consult them for every small things. If the BP goes up, we'll consult them. If the sugar goes up, we consult them. That we do because if you have a facility of physicians, better take their help. But not all the time they understand this better. We understand the hypertension and hyperglycemia better than the physicians because we know in pregnancy, certain antihypertensives cannot be used. ARBs, ACE inhibitors cannot be used. They are the favorite of the physicians. Similarly, insulin analogs are the favorite of the physicians, but we need not, just because they say that, we need not jump and change into insulin analogs. Let's see what is the literature with regards to insulin analogs. Should we just do these fashionable things, or should we restrict to our well-known insulin? Insulin analogs increase the convenience of insulin therapy, obviously, greater acceptance and compliance resulting in a better outcomes, but no major safety concern as well. Reasonable to continue insulin, that is glargine, to achieve excellent glycemic control. Good evidence to use insulin detemir as first-line long-acting analog in pregnancy. Well, it can be used. It's not that we have to oppose that. We can definitely use it. But lack of definitive fetal benefits means that there is no strong need to switch a woman who is well controlled on NPH insulin. That's what I was trying to tell you. If you are happy with the old insulin NPH, there is absolutely no need to switch over to insulin analogs just because the physician says, or an endocrinologist makes fun of you. What is this? You gynecologists or obstetricians do not know anything about insulin analogs. Why don't you switch over to that? There is no definitive fetal benefits. So there is no strong need to switch. There seems little justification in using long-acting insulin analogs where the risk of hypoglycemia is low. What do NICE guidelines say about insulin analogs? They are very smart and they have used very fantastic words, not beware. They said be aware. That's the choice of word. That data from clinical trials and other sources do not suggest that the rapid-acting insulin analogs, that is Aspart and Lispro, adversely affect the pregnancy or health of the fetus or newborn baby. Use Isofen insulin as the first choice for long-acting insulin during pregnancy. Isofen, not the analog. Consider, use the word again, consider continuing treatment with long-acting insulin analogs, detemir or glargine, in women with diabetes who have established good blood sugar control before pregnancy. Very smart way of putting it. Suppose the lady was a type 2 diabetes and she was under control, and then she becomes pregnant, and that control was because of insulin analogs. Continue that. There is no need to change that. But if you are happy with Isofen, that is the first choice of insulin during pregnancy. They have told both, so it is up to you. Intrapartum management is very important. Labor has glucose lowering effect, as you know, so lower insulin required. That's why in the latent phase, maternal metabolic demands are minimal, sufficient insulin produced to maintain euglycemia. In the active phase, however, phase of intense exercise with increased energy requirement, hepatic glycogen stores are also rapidly depleted. So you have to be very careful while using insulin during pregnancy, during labor. Intrapartum targets, ideal target, not clear, as neonatal metabolic outcome depends on many factors, that is antepartum glycemic control, gestational age, birth weight, pregnancy, and neonatal complications. Both ACOG and NICE guidelines, they say the target is around 72 to 126, somewhere between that. Maybe you can take it as 100. Easy to remember. Levels above 180 are associated with fetal hypoxemia acidosis, neonatal hypoglycemia when you suddenly stop it, and maternal ketoacidosis. So 180 is the limit. On the day of delivery, what we do in Manipal is in a planned delivery, that is cesarean or induction, we skip the morning dose of insulin, and 5% dextrose with neutralizing dose of insulin, that is 6 units, is added. The logic behind that is 1 unit will take care of 15. And if you are giving 6 units, that will take care of almost 90 to 100. So we have to, and in a 5% dextrose, how much of this one is there? 1 gram gives 4, isn't it? 1 gram gives 4. So 5% means how much? 1 ml contains, or 100 ml contains 5 grams, and 500 ml contains 25 grams. 25 into 4 is 100. So you can manage with the 6 units. Very easy. GRBS every 2 to 4 hours, and urine ketones at the end of every pint. If patient comes in labor, what to do? Suppose she has already taken the morning dose of insulin and she comes to labor at around 11:30 in the mid-morning. No problem. You suspend the insulin regime from that point. So whatever she was taking in the afternoon, night, you should not give till she delivers. So what you do is add 1 additional unit to the trip. 6 units is already there. For every rise of 10 milligram per DL over and above 180. I told you 180 is dangerous level. So up to 180, nothing extra to be given. The 6 unit which is there in the drip to neutralize the 25 grams of sugar that is present in the 5% dextrose. Subcutaneous regime is given 1 unit of subcutaneous insulin for each 20 milligram DL increase in the glucose level above 120. So that is only if it is increasing over and above 180. Postpartum, again, insulin requirement drops swiftly. You should know that 5% dextrose with neutralizing 6 units is continued. GR-based and urine ketones are done at the end of every pint, same as labor. 1 additional unit to the drip every rise of 10 milligram over and above 180. It's the same thing again. That is, again, as I said, if GR base is 200, 6 units is there already. How much is extra? 20 milligram is extra. For every 10, you give 1 unit. So 6 plus 2 is 8. If urine ketones are present, you give additional 10 units subcutaneous. Post-operative management, once the orals are started, titrate insulin as per GRPS. Usually they require 1/3 to 1/2 of their pre-delivery insulin. This has to be kept in mind. Watch for fall of sugar levels. Switch over to metformin. Strongly encouraged to breastfeed for its benefits. So patient will lose weight also by giving breast milk, and she will have a better control. Nice guidelines say offer lifestyle advice, encourage breastfeeding, offer FBS at 6 to 13 weeks. If FBS not done by 13 weeks, offer HbA1c. Do not routinely offer 75 gram OGTT at the end of 6 weeks. You can manage with just FBS and HbA1c. Offer an annual HbA1c test for all these patients, because according to Gabby's rule, 15% of the patients can develop type 2 diabetes later in life, those who had GDM. Newer technologies, quickly go through that. Reflection meter is there, but it is not very, very popular because there are a lot of problems with this continuous glucose monitoring, because they will have a lot of problems. You have to take sugar levels at every 10 seconds, total of 288 measurements. You will get the hypoglycemic events, 60% of insulin treated patients, 28% of glyburate treated patients, and 0% of diet alone or non-diabetic subjects. So this is how the picture looks like, so confusing, but the reliability problem of adjustment of therapy due to wide variability of day-to-day glucose levels in pregnant with GM. Fine-tuning of insulin regimens based on 3-day measurements with CGM method is not advisable. Then there is something called continuous subcutaneous insulin infusion, almost like a artificial pancreas. The problem with this is severe hypoglycemia, a high rate of ketoacidosis, infection, and the pump causes just $5,000. What's the future? Closed loop system such as artificial pancreas, but you have to know that safe delivery device that stores and releases insulin is important. Accurate glucose sensitizing unit is also important, and that controls and modulates delivery of the insulin is also important. Operate correctly all the time, avoid errors leading to severe hypo or hyperglycemia. Contraception, of course, you can avoid OC pills, better to use LNG IUS and conventional contraceptive methods. This is the guideline. You can take a screenshot because anytime the time may be over. As you can see here, it is moderated as no restriction, 2 is advantages of using method, and 3 is theoretical or proven risk, and 4 is unacceptable health risk. Only combined hormonal pills are contraindicated in diabetes with vascular disease or duration more than 20 years. All others are around advantages of using the method generally outweigh the theoretical or proven risk. Everything is almost given 2 or even 1. Thank you very much for your patient listening. I'll come up with another topic tomorrow.